cause of blindness is very simple, the uncorrected refractive error and cataract, which is a cause of preventable or easily curable blindness. And majority of these people are 50 plus, and in terms of economic loss or economic burden, this amounts to almost just only uncorrected myopia and perhaps alone, which is only refractive error, estimates around loss of $244 billion and $25 billion in terms of myopia correction and presbyopia uncorrected, the economic loss. So internationally, the vision loss is based on the degree of vision a person has is divided into mild, moderate, severe. I won't go into details. All of you know the definition of this. And as far as prevalence is concerned, as we have already told, that the refractive error is the most common cause, followed by cataract, glaucoma, and corneal blindness accounts for 4.2 million people world over, followed by diabetic retinopathy, trachoma, and unaddressed cause like presbyopia and all. If we go to the statistics, the prevalence rate world over is approximately around 3.5%, and in India it's around 5.5%. India falls in South Asia. And again, this is again a figure from Lancet. They have also shown the leading cause of prevalence of blindness to moderate and severe degree is either uncorrected refractive error, the blue bars, and the cataract. So these form the major chunk of blindness in world over. So is true about India. So this was a recent survey conducted by AIMS, and this was a rapid assessment of vulnerable blindness strategies, and they showed that the major cause of blindness in India more than 50 years again was cataract, and in India the corneal opacity is causing much more blindness as compared to the other countries, and of late even the complications of cataract surgery have added to this. 8% is very high figure. It means we need to train our people even in cataract surgery so that the surgery induced blindness can be brought down, and this is the cause of blindness between from 0 to 49 years. And if you see here the corneal blindness in less than 50 is to a huge number of 37%. So the previous figures we used to talk from since 1984 that only 10 million people are blind from corneal blindness is not true. There is a huge burden of corneal blindness in India, and this is just to show in a pie diagram again the same thing. This was 2001 survey where the cataract and all those things and the corneal blindness was just 1.2%, and this is the recent survey which has shown that corneal opacity accounts for around throughout all age groups around 7.8%. So the corneal blindness can be eliminated mostly by corneal transplantation, and for that eye banking, quality eye banking is of absolute importance. So Dr. Niti Gupta has already highlighted how the eye bank works. Any bank only works when there is an inflow of money or inflow of eyes, and then starts the work of eye bank, where it is to be stored and processed and analyzed whether it is fit for transplantation or not, because even she has shown in any eye bank only 60% of the cornea are worthwhile for transplanting, rest of them are discarded because of one reason or the other. Once the tissue is fit for transplantation, then comes the distribution, which should be fair and equitable. So it runs 24/7, as you all know, and we have around nationally 5 training centers and approximately 45 eye banks and almost 2,000 eye donation centers, and the corneal harvesting can be done either in the form of whole globe but the recent trend is towards in situ corneal scleral limb, which is much more practical. So I won't go into details of all this, but the recent trend is to retrieve a corneoscleral limb, and then comes the role of tissue processing. Once the eyes or tissue is received in the eye bank, it has to be done in an aseptic manner under a lamellar flow hood. All the serology tests are done so that it's safe for transplantation, and then it is preserved in different tissue. Of late, we have these tissues of cortisol, which is manufactured in India only, and in this you can preserve the eye for 7 to 12 days. So here you can plan your surgery in a better way. Logistically, previously we were used to store the eye in moist chamber. In this you have to use the eye within 48 to 72 hours. So there was a little hurry. So logistics was sometimes not met. Sometimes the eyes were there, the patient is not there, patient is here, eyes are not there. So we have now media where we can store these eyes for longer period and have a better suited patient and better outcome based on different preservation media. These are different. I won't again go into details of composition of this, and of late the trend has shifted from penetrating keratoplasty to the lamellar keratoplasty, and in those cases of lamellar, especially endothelial keratoplasty, the rate of fungal infections have increased because of the various reasons. Again, I will not go into details. For that, the recently the company has started adding amphotericin B in these tissue media, because the tissue medium is warmed again and again to evaluate the tissue. So once we are warming again and again, the risk of fungal infection increasing. And in the Western world, the organ culture is a very common method of doing corneal preservation. With this, we can preserve the cornea up to 4 weeks. And one of the greater advantage of this tissue preservation is, in this method of preservation, the corneal dendritic cell which resides in the limbus, they move out and the rejection rate becomes less. So, and a lifetime preservation can be done by cryopreservation. So once the eyes are received, they have to be assessed in the eye bank. So we have a very advanced endothelial count or evaluation specular microscope. Here also you have this a specular endoscope. So here we check for the quality of cornea in terms of endothelial function. Again, I will not go into details how we do it, because that is not the interest of this is how we look at the endothelium and we decide based on various criteria, coefficient of variation, hexagonality, and total count, whether the tissue is good, bad, or good for transplantation or not. Depending upon the quality of the tissue, it is graded excellent, good, fair, and non-analyzable or non-transplantable. So this is an example of excellent tissue for transplantation, because the endothelial cells are very good and regular, and this is coming to the clinical specular microscopy. Same way, patients who come for corneal blindness, we have to examine their cornea functionally. So we have clinical specular microscope, which also tells us about the same parameter as we do it in the eye bank about the various endothelial problems. Like here we have Fuchs endothelial dystrophy. So there could be variation of size, variation of shape, and sizes, as well as various anomalies like these guttae could be present in endothelium. So again, these are this is a case of Fuchs endothelial dystrophy. This is a case of eye syndrome, iridocorneal endothelial syndrome, where the endothelial cells on slit lamp appear like blabbing or swollen cells, but on specular microscopy, you can see they appear like epithelial-like cell. This is normal endothelium, and this is abnormal endothelium in the ICE syndrome. And again, this is Fuchs endothelial dystrophy, where you see the gutter, and this is ICE syndrome, where you see epithelial-like cell with prominent nucleoli. And this is a case of posterior polymorphous dystrophy. There's a band-shaped abnormal endothelium where you see epithelial-like cells. So again, this is a normal endothelium where all the parameters, count, coefficient of variation, hexagonality, everything is normal. And in older patient, the count decreases, and even the coefficient of variation changes. Young, they have less. Old age, they become more. This is the aging process. So coming to the actual, once we have analyzed the tissue, we have selected the patient, then you go on to do the actual transplantation. And of late, one tissue can be used for multiple recipients. That way, because in India we have always the shortage of corneal donations. So if we can use one cornea for 3-4 patients, that will decrease the demand of corneal donation and other things. Like here I'll show one case where we have used one cornea for endothelial keratoplasty as well as anterior lamellar keratoplasty. These are the various types of keratoplasty which are in vogue today. This is lamellar endothelial keratoplasty, Descemet stripping, automated or manual endothelial keratoplasty. DMAC is where only the endothelial part of the cornea is replaced, and which is becoming more and more common because this DSEC, manual and DMAC, the most important thing is it can be done anywhere because you don't need any special gadgets for this. It's all a manual procedure and the results are gratifying. So there you need not to do any extra investment if you want to do this manual DSEC and DMAC. And of course, this split corneal transplantation is enough evidence is there in the literature. So we can use the anterior part for dark or anterior lamellar, posterior part for endothelial keratoplasty. So this is one patient where we did a DSEC, manual DSEC. You can see the disc of the tissue and over a period of time the cornea clears up. And this is from the same cornea we use the anterior part for corneal granular dystrophy. This is the other eye operated in South India. There's a PK, there's a recurrent of dystrophy in the graph, and this eye did anterior lamellar, and the patient had a good outcome. This is patient had a 6/9 vision after a few days. So same cornea can be used for multiple patients. And coming to the DMAC, descent membrane endothelial keratoplasty, we know that the results of because the visual recovery time in the PK or DLEG, DSEC is approximately varies from 1 month to 12 months. PK takes about a year time for visual rehabilitation. But with the DMAC, the visual rehabilitation is very quick. Within a week's time, patient gains full vision, and it's very gratifying for the patient. So there are again enough reports how to prepare the Descemet membrane endothelial graft, and then how to insert it and do the endothelial keratoplasty. There are various techniques. So many techniques have been described to roll it, unroll it, inject it. And this is one represented patient. I'll show you. Patient came to us with a very less vision following cataract surgery. This is the patient who had, okay, this is not working. Following cataract surgery, he had bullous keratopathy. You can see the hazy cornea in this case, and there's a corneal edema, Descemet fold, everything. And I did a DMAC in this case 3 years ago. We have done quite a bit of number of DMAC graft, and I think this is not working. Maybe we can look for. Now, if it works now, we can see. Okay, so this can work now. This is the preparation of This is artificial chamber. You put the graft there. You stain it with the trypan glue. I will phosphor it. After staining it with trypan glue, you punch it with slightly punch it with a 9mm punch, and then separate the endothelium. Endothelium is just around 15 to 20 micron thick layer. So you have to be very. Okay, it's not coming. Oh. But in this it does. Okay. Oh, yeah. So this is the staining of the endothelium with trypan glue. And then we have to separate the endothelium from the trabecular mesh material. There are different techniques. Again, this is a blunt dissector. Then use with the coating with two microforceps or single, you dissect the endothelium. After dissecting, you punch whatever size you want to transplant depending on the pathology. Then you stain it again, because inside the eye it becomes difficult to see. So this is the peripheral part is removed, and then you punch the stroma, spread because you have to mark the stromal side of endothelium with the stamp. Otherwise, inside the eye, it becomes difficult to identify the endothelial or stromal side. So I have marked S. Now I will roll it into a roll. V is the best roll because that configuration opens up best. So this is a V configuration with the endothelium on inside, because we have to take it. So this is injected. So once this is the recipient preparation. In the recipient, you make an incision, mark the size of area where you want to remove. First you have to remove the defective desmet, score it, remove it. So this is the scoring of the endothelium. Then we remove it. I will just go forward. After removing that, you inject the endothelium and apply the suture so that it doesn't flow out. Once you have put the suture, you by gentle, again there are different techniques of unrolling the Desmet's membrane, air assisted or otherwise. Once we have put this thing, so you see, just inject a little bit of fluid, and by stroking and different maneuvers, you open it. Once it opens, you inject the air bubble. It sticks to the stroma, and that is the end of the surgery. So the patient, the next day, the vision is good, and this is first day. There's a little edema, and this is the OCT of the same patient. You can see the endothelial graft. This is after 2-3 weeks time. Patient has 6/9 vision. Quick rehabilitation. This is from the previous surgery. The previous surgery done elsewhere, complicated cataract surgery. You can see even the capture of the IOL. So this is way down. After 3 months, you can see the edema. Everything has disappeared. So this is pre-op picture, and this is the post-op picture. You can make out the difference in the clarity of the graft. So it's very gratifying for the patients. So this is just to show this. Another patient is one-eyed. He had already gone glaucoma surgery. Then I did a DMEC graft on December, this thing, and immediate, this is after 1 week. You can see the clear, this thing, and this is after 1 month. This is after 2 months. So the results are quite gratifying. So again, because if we compare the 3 types of keratoplasty, DMEC have the best results in terms of graft rejection, minimal graft rejection, as well as other issues, and vision regainment is much quicker, and if we compare the two, DSEC and DMAC, you can see the visual acuity achieved is much better in DMAC as compared to the DSEC graft. So this is another form of endothelial keratoplasty, the DSEC. Here instead of DMAC only, a part of posterior stroma is also taken, because here the handling becomes easier, because its DMAC graft is very difficult to handle. It is very thin, many times it flows out, so there is a learning curve to it. So to start with, people can do a DSEC, which is either automated or manual, and both studies have shown both have equal results in terms of visual acuity. And DMAC I have already shown, only the descendants is replaced. Here the stroma plus endothelium is replaced. And there are other therapies also, what we call DVAC. DVAC is, here you just do a descemetorexis, early stage of Fuchs endothelial dystrophy, just where the central part of the endothelium is defective. We can just score it and leave it like that, and we can again, there are ROCK inhibitors available now, which one of them is netrasodil, which inhibits ROCK enzymes and also helps in mitosis and migration of endothelial cells. Though now the things are moving towards non-surgical treatment, so early stage of Fuchs can be just treated with descemetorexis and with addition of ROCK inhibitors, which are available even in India. So these are the candidates which are amenable to this descemetorexis only. So this is a surgical technique for that. In this, you just mark central 3 to 5 millimeter area of endothelium, and then with the just forceps, you do a descemetorexis. That's all. You don't even need to transplant any tissue also. The tissue from the periphery grows, and the ROCK inhibitors also helps to in migration and possible mitosis of these endothelial cells. So it is just like capsulorexis, you are doing it on the endothelium. So it's not a difficult tool. You can have a reverse capsulorexis forceps. With that you can do. I have done only 2 cases of this, because our cases comes quite late, which are not amenable to this treatment. So there is enough evidence in literature that this procedure works. This is a case series of 13, which out of that, all of them don't improve. Almost 50% of them improve. So if it doesn't work out, you can always do a endothelial keratoplasty. So okay, so ROCK inhibitors we have talked about. So okay, I will just skip it because of the shortage of time. This is again descemetorexis followed by rho kinase inhibitors. So the case showing the improvement in corneal edema and the corneal clarity over a period of time. And again, it's the paper about the same thing, descemetorexis with topical ROCK inhibitors. So these are anecdotal studies.